All right, welcome to our deep dive on hip arthroplasty. Today, we're cutting through the noise to give you exactly what you, as a nursing student, need to know to absolutely crush your exams and feel confident on the floor.
Okay, so here's our game plan. We're going to follow a simple 6-part framework that takes us right from the core problem all the way through the essential nursing protocols. This is your roadmap for today.
First up, let's get to the 0-point foundation. What is actually broken here? If you get this one simple idea, everything else that follows is going to make perfect sense.
So here's the bottom line. See that smooth, shiny cartilage on a healthy hip? In our patient, that's worn away completely. So now you've got this painful, raw, bone-on-bone situation. The best analogy? Think of a rusty, grinding wheel bearing in a car. It's just not going to work right until you replace it with a new, smooth part. That's it. That's the problem.
Okay, so we know what's busted. Now, what's the fix? Let's get our official definition down so we're all on the same page. So, a total hip replacement is pretty much what it sounds like. It's a full-on swap of those damaged, grinding joint surfaces. We're taking out the old, worn-out parts and putting in a brand new prosthesis to get back to that smooth, pain-free movement. Simple as that.
All right, so how is this patient actually going to look and feel when they come to you? Let's connect that broken mechanism to the real-world clinical picture.
And this is key. Remember, the signs and symptoms you see aren't just a random list of problems. They are a direct, logical result of that underlying issue we just talked about, that grinding, worn-out joint. And this slide right here is pure gold for your clinical reasoning. It's all about the because clause. The patient has significant, sometimes unbearable joint pain because of that bone-on-bone grinding. And because of that pain, their mobility is severely restricted. See? It's a perfect cause and effect chain. Now we get to the fun part, your role. This is where you, the nurse, step in with critical assessments and you start putting your safety plan into action right away. I want you to really notice the shift in focus here. Before surgery, on the left, we're doing broad checks, blood work, ECG, to make sure the patient is safe for the OR. But the second they're out, boom, your focus narrows immediately to the right side of this slide, the 6 Ps. This neurovascular check is your absolute priority to make sure that leg is getting good blood flow and nerve function. Okay, if you remember one thing from this whole section, make it this. Your number one post-op risk is dislocation. That new joint is shiny and new, but it's not held in place by strong, natural ligaments. It can and will pop out if you're not careful. Your highest priority is preventing that. So, how do we prevent it? With these 4 non-negotiable rules. Seriously, burn these into your brain. Do not let your patient cross their legs. Do not let them bend past 90 degrees. No extreme turning of the foot, and no low chairs. You have to teach this, you have to reinforce it, you have to live it. So how do you enforce that first rule, especially when your patient is sleeping? Meet your new best friend, the abduction pillow. This simple wedge is your main tool. You place it between the patient's legs to physically keep them from crossing the midline. It's an absolute must-have. All right, pencils ready because this is the high-yield stuff for your exams. Let's frame your whole nursing care plan around the key nursing diagnoses that you're definitely going to be asked about.
Shocker, right? After a surgeon just sawed off part of your bone and hammered in a prosthesis, you're going to have some pain. Managing this is without a doubt your first and most immediate priority.
Now, the goal here isn't just to make the patient comfortable, it's about function. We have to control the pain so they can actually participate in their own recovery. And look at that second point. We give pain meds before physical therapy. That's not reactive, that's proactive. That's smart nursing. Okay, once the pain is manageable, our next big focus is, naturally, impaired mobility. We've got to help the patient start moving again, but safely.
And here's a really interesting point that a lot of people miss. Improving mobility after a hip replacement isn't just about the hip. A huge part of it is strengthening the rest of the body to help out. We get them using the trapeze bar to build upper body strength. We do range of motion exercises on the unaffected limbs. It's a full body approach.
Okay, we've talked about pain as a nursing diagnosis, but it is so central to everything we do post-op that we're going to do a quick deep dive into the how. What are the actual strategies we use to manage pain effectively? And it's so important to get the goal right. We're not trying to cure the surgical pain. That's impossible. We are managing the symptom. Why? So the patient can do the things that will lead to a cure, like getting up and walking with a physiotherapist. Uncontrolled pain brings recovery to a dead stop.
So, we've got a few great tools in our toolkit. We might use a PCA pump, which lets the patient control their own doses. We might use an epidural for continuous relief. Or we might use good old-fashioned scheduled dosing. The strategy behind all of them is the same: stay ahead of the pain. We want to prevent those severe peaks so recovery can move forward smoothly. And your job is to monitor these closely and educate the patient on how they work.
And that's our high-yield breakdown of nursing care for a hip arthroplasty. The big takeaway is this: if you understand the why, that simple, grinding joint, then all the what-to-dos just fall into place logically. Following the protocol is crucial, of course, but what's going to make you a truly great nurse is your ability to educate and empower your patient, turning them into an active, confident partner in their own recovery.